All right, so we're going to go ahead and get started. Good morning, everybody. Welcome to Medical Grand Rounds. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. Before I introduce our speakers this morning and their bios, I just wanted to take a minute for the clinicians and staff that have connections with Alberta Health Services. I know there's a lot of uncertainty this morning and some anxiety, and I just wanted to take this opportunity to let you all know that, while there is all the unknown out there, to just reassure you that, we are very much aware that there's a lot of anxiety related to the uncertainty, but there are areas where there are opportunities and stability. And so I will commit to you all that as much as I know, I will continue to share with you. Currently, we're learning things in leadership at the same rate that you're learning them in the media. So, as I learn things, I promise to make sure that I reach out to the folks that it impacts to let you know. But please, if you have any questions or worried about anything, please don't hesitate to reach out to me. So with that, I'm going to go ahead and introduce our speakers today. I'm delighted to start with Dr. Angela Lau, who is an assistant professor in the Division of Pulmonary Medicine. She did her core internal medicine and respirology training with us here at U of A and started her faculty appointment in pulmonary medicine in 2019. She's been working as a respirologist and TB physician at the UAH Edmonton TB Clinic and Provincial TB Clinic. Prior to working as a TB physician, she's worked with the TB Program Evaluation and Research Unit since 2008 and completed her master's in 2016. Her research interests are in TB epidemiology, subclinical TB, and her work has been funded by CIHR, Hospital Foundation, Respiratory Health SCN, and the Faculty of Medicine and Dentistry. We also have presenting with her Dr. Courtney Heffernan, who is a senior research associate in the TB Program Evaluation and Research Unit. Her interests include understanding transmission dynamics of respiratory pathogens, improving utility of surveillance data, and implementation science as they relate to the public health aspects of TB control. She sits on the steering committee. She's a steering committee member of Stop TB Canada, a member of the Canadian TB Elimination Network, and a member of the CDC's TB Trials Consortium Implementation and Quality Committee. And they're going to speak about the studies in subclinical pulmonary TB. So welcome.
All right, so thank you for the kind introductions. So Courtney and I will talk about our studies of subclinical pulmonary TB today.
Do you want to turn the mic off?
Oh, there we go. All right, hopefully everyone can hear me now. So I would like to also respectfully acknowledge that we are convening today in Treaty 6 territory, homeland of Métis. We pay our respect to the First Nation and Métis ancestors of this place, and we reaffirm our relationship with one another. I would also like to acknowledge our funding agencies, including Alberta Innovates, CIHR, Respiratory Health SCN, University Hospital Foundation, Department of Medicine, Alberta Respiratory Center, and Courtney and I have no other conflicts of interest to disclose. So our objectives for our talk today, first of all, we would like to define and review what subclinical pulmonary tuberculosis is. We will summarize some landmark studies of subclinical pulmonary TB from the TB Program Evaluation and Research Unit. And then lastly, we will describe some future areas of research and opportunities. So a bit of background, historically, TB has been conceptualized by some as consisting of either latent infection, which is asymptomatic and non-infectious, and active disease, which is symptomatic and infectious. However, recently it has become clear that respiratory exposure to the organism Mycobacterium tuberculosis can actually result in a spectrum of clinical and immunological outcomes. And between latent TB infection and symptomatic pulmonary TB, there are two intermediate states, incipient TB and subclinical TB. Incipient TB is defined as a state which is likely to progress to active disease, but does not cause any detectable abnormalities. And the second state, which we will focus on today, is subclinical TB, defined as a state of disease due to viable Mycobacterium tuberculosis organism that does not cause clinical TB-related symptoms, but does cause other abnormalities that can be detected using existing radiologic or microbiologic assays. We actually have a limited understanding of incipient and subclinical TB at the population level. Because incipient TB is not detectable, we know very little about its epidemiology. However, if we assume that active TB progresses through a disease state defined as incipient TB, then we infer that the incidence must be at least that of active TB. And as illustrated by the bidirectional arrow on this figure by Drain and colleagues, some patients with incipient TB do not actually go on to develop active disease. And thus we infer that the incidence of incipient TB is likely even higher than that of active disease. However, without kind of newer available diagnostic tools or biomarkers, incipient TB is very difficult to study, as you can imagine, just based on the fact that these patients have no symptoms and there are no existing radiologic or microbiological testing that can be used to detect these patients. Subclinical TB, on the other hand, is the earliest detectable disease state, and this has generated great interest. Its importance to public health is potentially substantial, given that such patients may continue to interact with others as normal for extended periods of time before either being diagnosed and treated or spontaneously reverting to an inactive state. So currently in the literature, the reported prevalence of subclinical TB varies widely across different epidemiological studies and depends a lot on the populations that are being studied, as well as the screening tools that are being used. There are two notable studies reporting on the prevalence of subclinical TB. First one is by Onozaki and colleagues, who reported on 21 prevalence surveys in 12 countries across Asia. They found that the proportion of smear-positive cases that did not screen positive based on reported TB symptoms, which was defined in their study as being a cough of more than 2 to 3 weeks duration or blood-tinged sputum, ranged from about 38% in Laos or 34% in Laos to 68% in Vietnam. More recent study by Frascella and colleagues published in 2021 used prevalence surveys in Asia and Africa, and they reported the prevalence to be between 36.1% to 79.7% of prevalent bacteriologically confirmed TB to be subclinical. The burden of subclinical pulmonary TB and its radiologic and microbacteriologic features in a high-income country was previously not known, though. We became interested in the study of subclinical TB through our previous research. So our research unit has demonstrated in earlier work a subclinical phenotype of pulmonary TB and the primary mode by which they are detected in Canada. And this led us to publishing some of the first work looking at subclinical TB in a high-income, low-incidence setting. We will go on to describe these studies in more detail today, and I'll also highlight some of our ongoing and planned work in this area. So in this first study, we determined the burden of subclinical pulmonary TB and the clinical mycobacteriologic and radiologic features among these patients. And to our knowledge, this is the first published study describing subclinical TB in a high-income, low-incidence setting. And the secondary objective of our study was to report on the association between DNA fingerprinting, clustering of MTB isolates, and radiographic or other features in subclinical pulmonary TB. So using a retrospective cohort design, we identified all adult subclinical cases over a 16-year period by reviewing their public health and hospital records and determining whether pulmonary TB patients were symptomatic. That is, whether they had one or more TB-compatible symptoms. So that was cough, hemoptysis, chest pain, or dyspnea, or any constitutional symptoms such as fevers, night sweats, fatigue, or weight loss. or whether they were entirely asymptomatic, which is the absence of these symptoms. We reviewed their mycobacteriological data, including their smear status, time to culture positivity, and DNA fingerprints of the initial isolates. And then collaborating with our radiology colleagues, we went on to describe the radiologic features on plain chest x-rays for these subclinical cases. So in our results here, what we found was that over the 16 years between 2005 to 2020, 1,656 adults were diagnosed with culture-positive pulmonary TB in Alberta. 1,307, or 78.9%, were symptomatic. 347, or 21%, were asymptomatic or subclinical. And 2, or 0.1%, had an unknown symptom status. We describe each of these 347 cases in more detail in the next few slides by their clinical and mycobacteriologic features. For our main radiologic analysis, which I will cover in my later slides, we did exclude 61 patients, including patients who had HIV or had a status unknown, declined images or had their images purged, and those with relapse retreatment disease. And that left behind 286 patients that were included in the radiologic analysis portion. So shown here is a comparison of the demographic features, disease type, and mycobacteriologic features of the 347 subclinical pulmonary TB cases compared to the 1,309 clinical pulmonary TB cases. And the same data is just represented here on a bar graph format, just for a better visual comparison. So compared to clinical patients, subclinical patients were more likely to be younger, foreign-born, to have relapse retreatment disease, to be smear negative, and to be HIV seronegative. And that's shown on the bar graph here. And these were all, as you can see, statistically significant. Subclinical patients also tend to have a longer time to culture positivity, with a median of 18 days versus 12 days, and a mean of 20.6 days versus 13 days. And that was also statistically significant. And what a longer time to culture positivity suggests is that there is a lower bacillary burden or less metabolically active bacteria in these subclinical patients. In this table, we describe the key radiographic features of new active subclinical HIV seronegative pulmonary TB patients. So typical adult type pulmonary TB was present on chest x-ray in 68.2% of these subclinical patients. Bilateral disease was present in around a quarter of these patients, around 24.5%. Cavitation and evidence of endobronchial spread or acinar shadows were quite rare, about 6.5% respectively. Cavities, when they were present, usually were quite small, with a median internal diameter of 13 millimeters, and they tend to be singular in about 73.7% of cases. The extent of parenchymal disease was normal in 18.9% and minimally abnormal in 67.5% of these patients. And not shown on this table here, but volume loss and pleural thickening or pleural retraction was quite uncommon, about 15% and 10% respectively. And pleural effusions were quite rare, about 2.8%. As you can imagine, because these patients are entirely asymptomatic, in this setting, patients are usually diagnosed during active case finding. So that is, for instance, during screening of immigrants and refugees, as well as contact tracing. So in the stratified analysis adjusted for age and sex, we compare the key demographic, radiographic, and mycobacteriologic features of these subclinical patients according to their reason for assessment. So we found that taken together, patients whose reason for assessment was extrapulmonary TB or a positive TST in IGRA were more likely than patients whose reason for assessment was immigration referral or miscellaneous other to have a normal chest x-ray, about 43% versus 8%. Most positive TST and IGRA patients were contacts of smear-positive clinical pulmonary TB patients, and of these, 70% had a normal chest x-ray. Patients whose reason for assessment was miscellaneous other or were more likely to have more extensive disease on chest X-ray and a shorter time to culture positivity. So here on the table on the left, we show the association of clustered MTB isolates by fingerprinting with age, sex, chest X-ray features, and time since arrival among the foreign-born patients with subclinical pulmonary TB. In this logistic regression, foreign-born patients with subclinical disease were found to be, or who are men with subclinical disease or had spent more time in the province were found to be statistically significantly more likely to have a clustered MTB isolate. No difference was found between the proportion of isolates that were clustered in patients who were older versus younger, with or without cavitation, or more extensive disease on chest X-ray. On the right pie charts here, we show the DNA fingerprint data comparing MTB isolates among the Canadian-born subclinical patients and foreign-born subclinical patients. So on the top there, most Canadian-born patients had a clustered MTB isolate, about 82%, and that's shown in green. Many of these patients were Indigenous. Most foreign-born subclinical patients on the bottom pie chart there had a unique MTB isolate, about 76%. Shown in yellow, and that actually suggests limited transmission among this group. So to summarize the findings from our first study, in this high-income, low-incidence setting, we found that subclinical patients accounted for 21% of incident culture-positive pulmonary TB patients. Subclinical patients were generally young, middle-aged, foreign-born persons diagnosed during their in-country immigration referral process, during routine assessment of the respiratory system in patients with extrapulmonary TB, during investigations of positive TSTs and IGRAs performed as part of contact investigation or employment screening, and during miscellaneous other activities. They were usually AFB smear negative, 88% or so, and had a longer time to culture positivity with a median of 18 days. Most had typical adult type pulmonary TB on chest X-ray, 68%. The extent of disease was either normal or minimally abnormal in 86% of subclinical patients. And finally, DNA fingerprinting data suggests preliminarily that transmission from subclinical patients was limited. In the second study, we looked at how likely a range of key radiographic features can be detected using CT versus chest X-ray in these subclinical patients. So diagnostic chest X-rays and CTs of the subclinical patients described in the previous study were reacquired and read by 2 independent readers and then arbitrated by a 3rd expert reader. Chest X-ray and CT features were defined by the data dictionary shown here, which I won't go into detail here, but included category, laterality, cavitation, endobronchial spread, adenopathy, and extent of disease. Again, of the 347 subclinical patients, 296 were HIV seronegative and new active cases, and chest X-rays were performed in all but 10 of these patients. CTs were performed in 94 of the 286 HIV seronegative new active subclinical patients who had a chest X-ray. We quantified the level of agreement between the readers for chest X-rays and CT scans by reporting their generalized kappa statistics. So kappa statistics for the chest X-ray features showed substantial agreement for category, laterality, lymph node enlargement, and extent of parenchymal disease, and moderate agreement for cavitation and endobronchial spread. Kappa statistics for CT scans showed almost perfect agreement for category, laterality, cavitation, and extent of parenchymal disease, substantial agreement for lymph node enlargement, and moderate agreement for endobronchial spread. In this logistic regression model, which was adjusted for age and sex, we found that laterality, cavitation, endobronchial spread, hilar or mediastinal lymph node enlargement, and moderately advanced or greater parenchymal disease were more likely to be present on CT than on chest X-ray, with their respective odds ratios shown below. And just kind of demonstrating that here visually, you can see that this is a frontal chest X-ray shown on figure A, and accompanying coronal CT images in a patient diagnosed with smear-negative, culture-positive subclinical pulmonary TB. You can see a small cavity is visible on the CT scan in figure B and C, and the abnormality is in the right upper lobe. In figure B and C is seen to be stable over several months, whereas the cavity is not visible on the chest X-ray. So in summary, when strictly defined, most subclinical pulmonary TB patients have minimal or no lung parenchymal disease apparent on the chest X-ray. When CT scans are performed in the same patients, the chest X-rays may be shown to underdetect significant key features. Cavitation was 4.7 times, endobronchial spread 19.36 times, extensive lung parenchymal disease 3 times more likely to be present on CT than chest X-ray. Almost certainly, there is a radiologic mycobacteriologic gradient of transmission risk within these subclinical source cases. And this may have potential importance to transmission risk as well as to treatment duration. And then in this third study, we wanted to know how well do field readers performed at making the diagnosis of subclinical TB. As you can imagine, in the absence of any symptoms, the epidemiologic risk of a patient, along with the chest X-ray alone, becomes central in considering a diagnosis of subclinical TB. So in the study, we abstracted the field radiology reports, and the information shown on the slide was systematically abstracted. In brief, the kappa statistics for the expert readers showed moderate or better agreement for all the features, whereas when we look at the kappa statistics for the field readers compared to the expert readers, it was much lower for most features, and agreement was actually only considered to be fair for cavitation. Field readers were less likely to report parenchymal disease and cavitation than the consensus of the expert readers. Underreading by field readers versus the expert readers was more common, and overreading less common for extent of disease, cavitation, enlarged intrathoracic nodes, and pleural effusion. So in summary, we conclude that chest X-ray abnormalities in subclinical patients are subtle. Field interpretation of chest X-ray increases the likelihood that these features will be missed. Field readers were less likely than expert readers to report a lung parenchymal abnormality and cavitation, and underreading was more common than overreading for most features. Therefore, we conclude that if during active case finding, the chest X-ray alone without use of sputum is used to rule out subclinical pulmonary TB, for example, in migrants with a chronic lung abnormality or during contact tracing, then we might be missing many subclinical pulmonary TB cases. And this may actually have impact on treatment outcomes as well as on drug resistance. So ideally, induced sputum should be submitted regardless of the chest X-ray findings, and chest X-rays should be read by experienced readers when possible in the context of active case finding. Of course, in developing countries, that's not always possible to have chest X-rays read by experienced readers. And Courtney will mention this towards the end of our slide, but we are looking at the performance of computer-aided detection system to diagnose subclinical TB. And I'll hand it over to Courtney now.
Thank you. Trying to figure out how to get myself seated up here. Okay, thank you. Is the microphone picking up in the room? Okay, perfect. So thanks to Angela for extending this invitation to me to have join her. I'm going to be talking about the final study here, and thanks for bearing with us, this very information-rich presentation. So as Angela described, given that subclinical pulmonary tuberculosis is characterized by a lack of symptoms, these patients enter the TB prevention and care services pathway primarily through active case finding activities or else incidentally. And one significant route, which was highlighted in her table, is through parallel investigations to an extrapulmonary TB diagnosis. of which peripheral lymph node TB disease is now most common. So the prevalence of pulmonary TB disease among peripheral lymph node TB patients is unknown, and predictors of obtaining a positive specimen from the airways specimens is thus not well described in the literature, so be they demographic, clinical, or radiographic. So patients with peripheral lymph node TB disease alone are not usually considered a public health threat, and their incident disease signals only the likelihood of a past exposure to someone with infectious pulmonary TB. So the emergence of peripheral lymph node TB as the most common site of extrapulmonary TB occurred during the second half of the 20th century, and it follows this shift shown here in the country of birth of new immigrants to Canada from low TB incidence countries of Western Europe to high TB incidence countries of Asia and Africa. So prior, the commonest form of extrapulmonary TB here was genitourinary, just for people's interest. Primary infection with Mycobacterium tuberculosis is usually through a lung portal, and lymphohematogenous, I'm so sorry, anything ends ogenous, my mouth just like will not wrap around it. Lymphohematogenous spread is a natural sequela. So lymph node involvement is important to the adaptive immune response, and prior autopsy studies in non-human primate data support the idea that lymph nodes serve as long-term reservoirs of bacterial persistence. So we initially conducted a retrospective study over 10 years, and we included all patients diagnosed with TB in all of its forms in Alberta between 2010 and 2019. They were identified from the provincial TB registry, and then we grouped them according to whether they did or did not have peripheral lymph node TB disease using ICD-9 codes. So in Canada, peripheral lymph node TB is defined by the ICD as clinical TB disease involving extrathoracic and extra-abdominal lymph nodes. So patients with peripheral lymph node TB were defined as those who were culture positive for Mycobacterium complex species from their lymph nodes, those who had necrotizing granulomatous inflammation in their lymph nodes with or without a positive culture elsewhere, or those who had a clinical diagnosis of peripheral lymph node TB and were culture positive for Mycobacterium tuberculosis species from elsewhere. So the data in these tables show that peripheral lymph node TB patients, as compared to all others, are more likely to be younger to middle-aged, female, and foreign-born. And I'll just show here in a bar graph. Both groups were equally likely to have had their disease culture confirmed, which is important. Both were equally likely to have had new active disease versus relapse or retreatment disease. And both groups were equally unlikely to have had drug-resistant TB and equally unlikely to be HIV co-infected. So that being said, our study here is not an epidemiological description of TB lymphadenitis that's already out in the world, but instead we wanted to estimate the prevalence of concurrent pulmonary TB disease, determine predictors of a positive sputum culture, and estimate the public health impact of peripheral lymph node TB-associated pulmonary TB disease. As a result, we refined our cohort as seen here according to these objectives. We pulled demographic and clinical characteristics from public health charts. And as in Angela's studies, sorry, someone was just wagging their finger at me in the audience, and had their chest x-rays reread by 3 experienced chest radiologists to categorize their features as relevant to TB disease. So you can see here that patients without a symptom inquiry, chest x-ray, and/or appropriate specimens were excluded from further analysis. And so that gives us a primary study cohort of 306. So we looked at chest radiographic features in peripheral lymph node TB patients split according to whether they reported classical symptoms of TB disease or not. So as Angela mentioned, these could be any constitutional respiratory symptoms. These would include fever, night sweats, weight loss, cough, chest pain, hemoptysis, dyspnea, or else none of these symptoms. So for chest radiographic features relevant to the diagnosis of TB, we categorize the chest X-ray overall according to whether it was typical or atypical for adult type pulmonary TB disease. And the definition of typical is an upper lung zone predominant disease with or without cavitation, but no discernible adenopathy. And an atypical chest radiograph, therefore, would be defined by abnormalities that are inconsistent with that definition. So just to illustrate, this chest radiographic image shown here in a patient with smear-positive cavitary pulmonary TB disease shows 4 cardinal features of adult-type pulmonary TB. We would call this a typical chest radiograph. So we have cavitation, it's labeled with the number 1, and an upper lung zone distribution. So if you imagine cutting the lungs in half from the diaphragm to the top, that would be an upper lung zone. We see that's labeled with the number 2. We see volume loss here labeled with the number 3, and acinar shadows, or if you, like me, are not a radiologist, this snow-like stuff labeled with a number 4. So we also describe the extent of parenchymal disease as normal, minimal, moderately advanced, far advanced, or miliary, according to the criteria established by the U.S. National Tuberculosis and Respiratory Disease Association. So what we'll come to see most interestingly is of the 235 patients whose lung parenchyma were normal, 32 did end up having sputum culture positive pulmonary disease, of whom 22, or about 70%, denied having any respiratory symptoms. So a subset of sputum culture positive peripheral lymph node TB patients whose lung parenchyma appeared normal on chest radiograph also had a CT thorax performed during their initial investigations. So you can see that even in light of the increased sensitivity of this imaging modality, 50% of the CTs were also judged to depict normal lung parenchyma. So these are some just examples of imaging among patients that were in a study. So on the left, you can see no enlarged nodes or adenopathy on the chest X-ray, but there is paratracheal adenopathy that's seen here on the CT. So in another on the right, the chest radiograph depicts normal lungs, but a grossly enlarged paratracheal node. Ultimately, this patient had sputum culture positive pulmonary disease and denied having any respiratory symptoms. So as I mentioned from the outset, we were primarily interested in determining whether any of the demographic, clinical, or radiographic features of peripheral lymph node TB patients predicted the likelihood of obtaining sputum culture. And so again, that's an indicator of pulmonary TB disease, and that's the potentially infectious TB disease type. So we assessed 306 individuals, and 63, or 20%, were sputum culture positive. So for this analysis, we used multivariate logistic regression. And you can see here that the reported respiratory symptoms and an abnormal lung parenchyma and chest radiograph were associated with obtaining positive sputum culture from patients who were contemporaneously diagnosed with peripheral lymph node TB. And HIV seropositivity was borderline significant and just underpowered in this group. So just to summarize here, peripheral lymph node associated pulmonary TB is not uncommon. Typically here is subclinical, so that means, again, the patient denies respiratory symptoms, and interestingly, their chest radiographs often evince no lung parenchymal abnormality. That being said, this raises some legitimate questions about pathogenesis, and the retrospective nature of our study, of course, doesn't allow us to know for certain how the organism is coming to be in both the peripheral lymph nodes and the lungs at the same time, but we've proposed several hypotheses for further explanation. So this is just an illustration here for reference. We see the normal lymphatic vascular system and its relationship to the cardiorespiratory system. So the first possibility is simultaneous reactivation of the organism in the peripheral lymph nodes as well as in the lungs. So due to the activity in the lung by the organism, this would most likely be typified by an abnormal lung parenchyma and chest radiograph. So in the context of our study, this is the likeliest pathogenetic mechanism that accounts for about 44% of sputum culture positive patients, or 28 out of 63. Next, the panel in the middle, we see peripheral lymph node TB and pulmonary disease may be associated with a primary infection. Primary TB infection results from a recent exposure. So we used contact histories to estimate the proportion of patients in our study to whom this hypothesis would apply. So in these instances, the lung parenchyma may be normal on chest radiograph. But as we tried to demonstrate here in this illustration, a common way for primary infection to present is as a pleural effusion in adolescents and adults. So finally, in the third panel, there are two other hypothetical mechanisms that may explain concomitant peripheral lymph node TB and pulmonary TB with what may appear to be normal lung parenchyma and chest radiograph. So in one, Mycobacterium tuberculosis reaches the lung by, lymphohematogenous spread. And in both instances, TB disease is due to reactivation, and in the other via retrograde lymphatic spread. So in both of these instances, TB disease is due to reactivation of a remotely acquired infection and sputum is positive. So some combination of these two mechanisms relate to about 50% of the patients in our study. So just to further clarify this image here, the cervical lymph node, which is labeled A, may drain through the central vein to go into the lung where it's going to get oxygen, and the organism is then deposited through the vasculature, labeled here in B. And or Mycobacterium tuberculosis from A may move backwards or retrograde through the lymphatics to be in the lung. So these findings are important because, as Angela mentioned, the public health consequences of peripheral lymph node associated pulmonary TB may be overlooked if the latter is not fully investigated. So we used contact tracing data and identified 402 close household contacts from 51 of 63 sputum culture positive patients and 78 of 243 sputum culture negative patients with peripheral lymph node TB. The program completely assessed more than 92% of these priority contacts and determined that among contacts of sputum culture positive peripheral lymph node TB patients, 35% had a new positive TST or IGRA, 5% converted a prior negative test to positive, and there was one secondary case of active TB disease. Meanwhile, contacts of sputum culture negative peripheral lymph node TB patients showed 30% with a new positive TST or IGRA and 1% as converters. No secondary cases of TB were seen in this group. So since the majority of peripheral lymph node TB patients in the province are foreign-born, and peripheral lymph node TB disease in the absence of a positive sputum culture is not by and large infectious, one can assume here that this rate of 30% TST or IGRA positivity most likely reflects the baseline rate of infection in this population. So in other words, this could be from undetected imported prevalent infection from high exposure settings to this low exposure setting here. So peripheral lymph node associated pulmonary TB disease increased TST IGRA new positivity findings and conversions by about 5% and secondary cases by 100%. So isocronous pulmonary TB in peripheral lymph node TB patients is common, especially in those with respiratory symptoms, abnormal lung parenchyma, and HIV co-infection. There's no single pathogenic mechanism that explains this phenomenon, and we make a strong recommendation for routine screening of peripheral lymph node TB patients for pulmonary disease with symptom inquiry, chest radiograph, and an induced sputum. just to summarize the implications here of all of this work, subclinical pulmonary TB patients comprise a substantial proportion of incident disease of the population. If these patients contribute little to transmission, then we may be able to recalibrate our programmatic efforts to more symptomatic cases. And if subclinical disease is more benign, then it could possibly be treated with shorter and less complicated regimens. So we have some planned and ongoing work here. We are working on refining our understanding of the relative rate of transmission from subclinical pulmonary TB patients compared to clinical pulmonary TB patients using whole genome sequencing. And for this, we have funding. We're undertaking a series review of subclinical pulmonary TB patients using quantitative CTs and post-treatment PFTs to determine the degree of injury or loss of function, if any, among these patients. And this is because post-treatment PFTs are now recommended for all pulmonary TB patients, but it's unclear whether they contribute any additional information or are necessary for this subgroup. We're interested in determining, like Angela said, whether computer-aided detection systems can assist in or be rolled out as contributing to the diagnosis of subclinical pulmonary TB for chest radiographs. And we've completed a study that explores the relationship between Mycobacterium complex lineages and the phenotypic expression of pulmonary TB disease. This is currently under review at the Journal of Infection. We're also extremely interested, maybe I'm speaking primarily for myself, but exploring the efficacy of shorter treatment regimens in this subgroup. And this would be made possible through our involvement in 2 clinical trials consortia. So the McGill International TB Center's Clinical Trial Consortium and the TB Clinical Trials Consortium of the CDC. And I don't know if anyone saw Karsh Chauhan's or John Mackey's paper yesterday. They described a new statistical tool that can improve insights for clinical trials data using smaller sample sizes. And I just think it's really exciting. So when you read mine and Angela's papers, maybe add that one to your list. And I just want to thank all of the staff and students that we work with at the TB Bureau and our collaborators from the clinics and the precision laboratories, radiology, et cetera. So thank you so much.
Thank you. That was fantastic. Maybe I'll just kick it off in terms of questions. So, you know, you've talked a lot about sort of trying to identify the subpulmonary group. And I'm just wondering from a frontline clinician perspective, the risk of transmission is not zero. And so to what extent does that historical fact of, do you have family members with subpulmonary TB, or, you know, sort of identifying that as a risk factor when you see patients that present with pulmonary disease that's undefined to date? And it takes longer as well to get, if they are culture positive, right? So are there any tips and tricks in terms of frontline clinicians and what we should be asking for, to identify high-risk patients?
No, I think that's an excellent question. I think you're right in that subclinical pulmonary TB patients, the risk of transmission in this group is not 0%.
Sorry.
It's not 0%. So I think that's why we in our program at our clinic as well, we do contact tracing in this group extensively, and like I mentioned earlier, we still do all the whole symptom inquiry, and even if they're asymptomatic, we do routinely submit 3 sputum specimens for AFB just for confirmation, and then we also will do a chest X-ray routinely on all these patients, and that's sort of how we are able to identify these subclinical cases. Yeah, so I think from a clinician perspective, we can't really ignore those contacts, and a lot of these contacts are also screened with TSTs and IGRAs as well, and that's also helpful because I think Courtney's study kind of highlighted the fact that a lot, you know, it might not just be from contact transmission or from these cases, but these cases may have kind of shared epidemiologic risk and may have imported latent TB from either from their home countries, etc. So yeah.
Yeah, I'll just add on to the last point that Angela is saying. I think like the epidemiological importance of place is underappreciated in a lot of clinical settings, and that's specific to TB, but also applies to other newcomer health needs. And so I just highlight that as valuable.
And ongoing testing as well, right?
Yeah.
Because you showed that it can be initially negative and then sort of come. So that's great work. Yeah.
Do I need a microphone or?
Well, I don't know if it's working now. It wasn't working yesterday or last week. So or the week before.
Okay. Hold it up. So, in trying to better understand the whole spectrum of latent and active tuberculosis, and also better predict who's a public health risk, what about nucleic acid tools, which are increasingly used all over the world, and you didn't really mention those. Where do they fit into the picture?
You have to repeat.
Oh, okay, I can repeat the question. So the question was, where do nucleic acid amplification testing fit into the diagnosis of subclinical pulmonary TB? So in our study, we do consider anyone that has a gene expert PCR or nucleic amplification test being positive as a microbiologically confirmed diagnosis of subclinical TB. So that's a great question.
Dr. Farrar.
That was a very nice thing. I just wanted to challenge the concept that so clinical TB is not important from in the epidemiologic point of view. Because, I mean, if we want to avoid transmission, those are exactly the cases we should target. I mean, of course, because we are positive, infectious ones are the most dangerous. But is subclinical TB an index of the sensitivity of our system to detect tuberculosis before it becomes dangerous?
Yeah, I think that's
just repeat the gist of it.
okay, sorry. The gist of the question was whether we're collectively underappreciating the contribution of subclinical pulmonary TB to the broader epidemic of TB with respect to transmission. I think it's a good question. I think it's unknown. I think the prevalence surveys suggest that there is quite a lot of transmission from subclinical TB, but I think that their symptom screens are maybe not as strict as the total lack of symptoms that we describe here among subclinical TB patients. And so that means lots remains unknown. I think if subclinical pulmonary TB patients contributed a lot to transmission, we would see failure of our concentric circle approach to contact tracing. You would expect that people who are undetected would be contributing here to transmission, and we would see more evidence of transmission here that isn't captured through our contact tracing efforts.
Mm-hmm.
So I think it's a great question. I think remains to be studied here.
Just a couple of questions online. So how does this work related to subclinical TB apply to screening prior to high dose steroid therapy or chemotherapy?
Yeah, that's a good question as well. So I know typically in patients with who's receiving chronic steroids, or if they're undergoing chemotherapy, they typically would get a TST and IGRA, and then if they are positive if they are positive, then typically they would be sent to our clinic, or referral would be sent to our clinic, and we will routinely send off a chest X-ray on these patients, and we will routinely send off sputum on these patients. Going back to Stan's question, I should clarify, we do not routinely send off nucleic acid amplification on these patients. So we don't send a PCR on everyone. It's just too costly to do that. So we don't have that incorporated in our algorithm, but in our clinic algorithm, we do We do try to screen out any subclinical patients or active cases prior to either starting them on latent TB treatment and before they initiate chemotherapy or steroids.
And presumably if they're positive, then treat
Yeah,
before, yeah.
exactly.
So just a interesting question. Did your work look at in the immigrant population with subclinical TB, if they had received INH or rifampin prophylaxis in the past because of exposure history? So if they had received prophylaxis, was there a higher or lower likelihood of them having subclinical TB? I don't know if you studied that or not.
No, we did not look at that. That is an interesting question, though. No, we did not explore that. Give a little bit of a difference between latent TB and subclinical. Yeah, so kind of going back again, latent TB, we kind of deem as being not microbiologically active organism, whereas in subclinical TB, these patients have culturable microorganisms that can be detected either using existing microbiologic assays, so whether it's GeneX or PCR positive or sputum culture positive or existing radiologic assays. And then gonna make one other distinction is in patients that have in patients who only have one culture that is positive, we would routinely call the lab as well to make sure that there's no laboratory contamination, and that's and we exclude that possibility as well.
Angela, you guys talked a little bit about extrapulmonary lymph node TB. What about other forms of extrapulmonary TB? Is there any kind of, like, have you done work to look at the likelihood of conditions related, to other forms of extrapulmonary TB with subpulmonary?
Sorry, I sort of skimmed over something because I had the impression we were running out of time, but the program here is very aggressive in going after the organism for culture, and the lungs are a high yield site for the organism. And so in the instance of peripheral lymph node TB, if there's no tissue left to culture, you could see from the cohort here that almost all had an airway specimen collected. And so that may also be the case for other extrapulmonary TB disease types, but we didn't
Haven't looked at that. Do you have any theories about that?
I think it's common here for the program to try and collect the organism from the lungs as well. I don't know what the yield is for all of these other extrapulmonary disease sites. So yeah.
And then last question for me, but you talked a little bit about genomics, and you have some funding to study that a little bit. But I wonder if you can share any insights that you might have in terms of genomics and whether you found a correlation with pulmonary. Look, Angela has a big one to say.
Yeah, we're quite excited about this. Actually, Dr. Long is giving rounds on this next month, and that's why we didn't incorporate it into our slides here. But we have been looking at whole genome sequencing to determine lineage. And we found that majority of the subclinical cases have an ancient MTB lineage. Compared to clinical cases who have a modern lineage. And kind of to break it down easily, easier to understand, we think that these subclinical cases and their ancient lineages of Mycobacterium TB has been around for many, many years, and our body our human host have been able to adapt to kind of the ancient lineages, and that's why we manifest less symptoms, less overt symptoms or less clinical pulmonary TB symptoms compared to clinical TB cases who typically have a more modern MTB lineage. So we found that work quite exciting, but we'll learn more about it next month. And the paper is currently in review right now.
Interesting. Do you want to add something?
Well, there's just another comment in the chat here. Would treatment of patients with subclinical TB with shorter courses of treatment cause development of more drug-resistant TB? I'm not sure that monotherapy necessarily would be appropriate in this group, but I'm also not sure that treatment with regimens for TB infection haven't been used successfully in this group because of the lack of symptoms and full workup in other areas. So yeah, it's a good question, a valid question, but I'm not sure to what extent it would induce drug resistance.
Yeah, and I think that needs to be studied through larger clinical trials, and that's kind of a question that, as Courtney mentioned, we would like to pursue through larger clinical trial consortiums.
Or
Yeah.
smaller now, given this new
Yeah.
statistics.
Yeah, one more.
Oh, is this even?
I don't know.
Just about MGR and subclinical. Did you guys study that and like if there is a correlation, what the percentage is?
That's a great question,
And
Melanie. So the
repeat it.
question was whether we looked at whether subclinical cases have an increased rate of MDR or drug resistance, and we found no difference among clinical versus subclinical cases. There's no difference in drug resistance.
Yeah. Thank you. What an important area, and sounds like there's still a lot of work to be done. So great job to all of you and obviously the program. So on behalf of the department, thanks for the presentation.
Thank
Thanks
you
so
for
much.
having us.
Yeah.